management of ischemic stroke. Here we will be dealing with management of thrombotic stroke, and embolic stroke will be considered later in a separate video. The first thing that has to be done is to rule out the presence of hemorrhage. So it is always useful to go in for a CT because CT can rule out hemorrhage. If MRI is available, it is best to do MRI, but it will take some time to get the MRI done, and also it is not affordable for many of the patients. Hence, CT can be taken to rule out hemorrhage. But infarct in a CT appears only after 48 to 72 hours. So, the prime aim for taking a CT in a case of suspected CVA is to rule out hemorrhage. Once hemorrhage is ruled out, we have only two possibilities. One is thrombotic, other is embolic etiology. If the patient has presented to us within 3 hours or to the maximum of 4.5 hours, which is considered as the golden time in case of cerebrovascular accident, patient can be thrombolized with alteplase. The dose is 0.9 mg per kilogram, 10% of which is given as bolus, and the remaining is given as infusion over 1 hour. These are the indications and contraindications for thrombolysis. Indication: the patient should have a diagnosis of stroke and the time should be within 4.5 hours from the onset of the symptoms, and the CT scan should not show any hemorrhage, and the edema should be less than 1/3 of the MCA territory, and the patient should be 18 years and above. Contraindication: if the BP is above 185 by 110, it is one of the contraindications for thrombolysis. If the patient has some bleeding diathesis or history of recent head injury or major surgery within the past 2 weeks and GI bleed in the past 3 weeks and recent MI, these are the contraindications for thrombolysis with alteplase in a case of CVA. So regarding the administration of alteplase, the dose, as we said, is 0.9 mg per kilogram. Blood pressure has to be monitored frequently, and no other antithrombotic measurements should be given. Measures should be given for next 24 hours, and you have to avoid catheterization for 2 hours because it will cause torrential bleeding. Suppose if the patient presents to us after the golden period, that is after 4.5 hours, we can go in for oral antiplatelets, of which aspirin is the preferred drug, and statins and physiotherapy. Physiotherapy has to be started at the earliest. Regarding BP control, many of the patients presenting to us with CVA will have elevated BP. This BP is one of the cerebral autoregulation done to prevent the ischemic penumbra region from getting infarction. So the BP should be reduced if it is above 220 by 120 mm of mercury, or if we are planning for thrombolysis and the patient has presented to us within 4.5 hours, the BP should be reduced to less than 185 by 110 mm of mercury. This is the infarct zone. This is the ischemic penumbra region. That is, blood flow can go here, but it has to go with lot of pressure. Hence, brain automatically increases your blood pressure to maintain perfusion to this ischemic penumbra region. This region cannot be done anything because it has gone in for infarction. So the increased BP in CVA is a protective reflex. If you reduce the BP, this ischemic penumbra region will further go in for infarction. So BP should not be reduced, and it should be reduced only if it crosses more than 220 by 120 mm of mercury. Even if the patient is a known case of hypertensive, BP drugs can be withheld for the first 3 days with continuous BP monitoring. Sugar control: neither hyperglycemia nor hypoglycemia should be produced to the patient. So blood sugar has to be maintained between 60 to 180 mg of deciliter. Remember, 180 and 180. That is, the golden time is 180 minutes, that is 3 hours, maximum 4.5 hours, and the BP should be around 180 and blood sugar should be around 180 mg of deciliter. Supporting care, apart from this, supporting care is a must. Nasogastric feed if the patient cannot tolerate oral feeds and has recurrent aspirations, and frequent change of position to avoid bed sores, and physiotherapy at the earliest. Elastic stockings and heparin for prophylaxis against DVT. It is DVT, sorry, DVT. And UTI has to be avoided, and aspiration pneumonitis. Fever is detrimental, so fever should be avoided. Cerebral edema is one of the complications seen in CVA. It mostly develops on the second day, though it can occur on any day. Most commonly it occurs on the second day. Anti-edema measures that can be tried are elevation of the head and mannitol at 1 gram per kilogram dose and hypotonic saline. Anticoagulation, most of the studies have demonstrated no additional benefit with anticoagulation in case of CVA.